Hello, I'm Nick, one of the consultants, and this is Chris. And I'll let Chris talk first, and then I'll talk.
Yeah, thank you very much, Nick. So I'm Chris, and I'm the other kidney consultant at the St George's TS Clinic. And could you go on to the next slide? I think that's the summary one, Nick.
Cool. Yes.
Yes. So this is how we'd planned to talk. I was going to do a quick overview of TSC, and then I'm going to hand over to Nick to talk about the service at St George's. And then we'll go on to progress so far at the clinic, what we think we need to do next, and a bit about research focused on the clinic. Right. Next slide, please, Nick. I feel like I'm doing a COVID presentation here.
Right. Thinking that, Chris.
Chris Whitty.
Yeah. So, but this is for people who are new. Some of you, a lot of you, this will be old hat. But as many of you know, TSC is an autosomal dominant genetic disorder. That means there's a 50-50 chance of passing on if you've got it. It's rare-ish, but not that rare as genetic diseases go. And it does increase the risks throughout life, particularly if the problems it causes are not well treated. It probably occurs in something like 1 in 7,000 people. So that means about 2 million people worldwide have TSC. We know the precise genetic cause. It's damage to one of 2 genes, TSC1 or TSC2, which make proteins that work together in a pathway of inside cells called the mTOR pathway. And that pathway is involved in helping cells to grow and divide. And it's turned on when they need to and turned off when they don't. When TSC1 or 2 genes are damaged, those cells that have both copies of the gene damaged turn themselves on and don't turn off, and that's the problem. It affects all races, all genders equally. It affects children and adults, but of course it starts early, either inherited, and so therefore at the egg stage in the womb, or very early when someone's still a fetus in the womb, within the first 12 weeks. And as I say, it can cause benign tumours and poorly formed organs, particularly problems in the brain. Next slide, please, Nick. And the things that cause in the brain, you'll see here something. The black arrow points to a subependymal nodule, and these are generally benign on the lining of the water space in the brain. But on the right-hand side of this slide, you'll see a larger white thing, which is one of these nodules that started to continue to grow and form what we call a saga. And those can be very successfully treated nowadays, but they need to be detected. Next slide, please, Nick. And again, these are the kidneys. Angiomyolipomas, which are sort of benign fatty lumps of blood vessels, fat cells, and muscle-like cells, affect about 80% of people with TSC, and in about half of those, they need treatment. And one of the themes of this talk is going to be that most of the major things can be treated, and it's good to monitor people and find them early. Cysts are also a problem, and they occur in about 30% of people, and sometimes they can affect kidney function. And then very rarely you can get renal cell carcinoma, which can be treated by surgery, but it needs to be spotted and differentiated from the AML. Next slide, please, Nick. And one of the earliest ways we find TSC in people, particularly when they're still in the womb as a fetus, is by finding little lumps in the heart called rhabdomyomas. And for most people, these don't cause any major problems, but sometimes they get big enough to cause trouble, and sometimes they need treating. And we can discuss ways of treating if you like later, but there are ways. And then what used to be one of the most feared complications in TSC for later on occurs mainly in women, but again, this is something else that's treatable if caught early. Next slide, please, Nick. And as you'll know, TSC can be seen in the skin, the nails, there's white patches on the legs or anywhere on the body called white macules. And doctors can also see it in the back of the eyes, these so-called patches or astrocytic hematomas. Don't usually interfere with vision, but they're a way of diagnosing TSC. Next slide, please, Nick. And this is the new diagnostic criteria. These were revised last year at the international conference, and it's now sufficient to have a known mutation of TSC1 or TSC2 that is known to cause problems, or a mixture of these other features, the major and minor ones. And for a firm diagnosis of TSC, you need 2 major features or 1 major and 2 or more minor ones. But there are some people with only 1. And it's always difficult to know whether they just have a very mild form or whether it's coincidental, because occasionally you can have a bit of local TSC in one bit of one organ, like a white patch on the skin that doesn't affect the rest of the body. But these are what we work on in terms of definition. Next slide, please, Nick. And there is a timeline to these outcomes. The heart issues, this bar in green, can be picked up very early, as can the brain signs. And the brain signs can even be picked up at MRI when babies are in the womb sometimes, but usually present later, and it's usually in infancy when people have developed epilepsy and the cause is looked for, that most people are diagnosed. The epilepsy can come out later in some people, but skin manifestations start in childhood and can be and often get worse as people get older. The kidney tumors and the lung problems, or the kidney tumors probably start much earlier, but we can't see them because they're too small. And as they become bigger, they become easier to diagnose. What's not on this slide is TAND, which it describes the psychological bits that can affect people with autistic spectrum disorder, learning disability, anxiety, sometimes depression. And those are very common, and they're one of our challenges to treat well. Next slide, please, Nick. However, some of the problems are now much easier to get on top of. So the brain saga, almost always that can be adequately well treated. You'll see some green boxes here. These refer to trials with everolimus. Brain sagas can be treated with an mTOR inhibitor like everolimus or sirolimus, or surgery, but in most cases we prefer the tablets. Kidneys, so in most people nowadays, if we diagnose problems early, we would expect to be able to treat those problems and not run into significant issues later. The same with LAM. LAM can affect people's breathing, but nowadays we would hope to prevent almost all of that. Resistant epilepsy is more of a challenge. We do have some effect with everolimus, but it's still one of the major problems that we're trying to get to grips with. And there are things coming along that will help, new anti-epileptic drugs, cannabidiol, and then eventually new forms of mTOR inhibitor. And the facial rash and the skin manifestations in general, they also respond to mTOR inhibitors, and there's other local treatments we can try. But again, TAND, the neuropsychiatric problems, that is the autism, the learning disability, are still a challenge. We know from the EPISTOP study that Professor Józwiak and his colleagues started from Poland in Europe, that treating difficult epilepsy very early and even before it really gets going makes a big difference to who ends up with much TAND or very little of it. So prevention is one of the tasks, but we're also looking at ways of treating it, and we talk a bit later about the TAND app. And next slide, please, Nick. And so one of the biggest advances for tuberous sclerosis over the last 2 decades has been not just the discovery of how it's caused, this mTOR pathway in the TS cells that is overactive, but also a drug to damp that down and return it back towards normal. And everolimus is one of those drugs, and it was licensed for treatment of refractory epilepsy, and before that, SAGA and AMLs. And you'll see the dates here of the various licensing. Next slide, please, Nick. But most of that really hard graft in terms of lobbying the government and getting them to fund the treatment was achieved by the TSA. So thank you, TSA. You've done a fantastic job. And this, if you haven't got this leaflet, I would certainly get it from the website. This is the summary of what to look for and how to manage it over the sort of lifetime of TS. And so this is something good to have in your kind of medical file. Next slide, please. And I think this is the handover slide. Is that right, Nick?
This is indeed the adapted handover slide in which we kind of bring everything together. And yes, anyway, hello, I'm Nick. I'm another kidney doctor. Chris is the senior pair of hands. I am the junior trainee, and thank you very much, Chris. So let's introduce you to what we have at St George's. It's wonderful to see so many of you here. I think that I do recognise a number of you from our very clinic. So we may well be merely telling you what you already receive in our clinic already, or hopefully you've experienced, but maybe you'll see that we are able to offer a little bit more or less than you've already experienced. So we were founded initially in 1993. So I think it was 28 years ago. It's 29 years old this year, with pump prime funding from the TSA. So all roads lead back to the TSA. So thank you once again for all of that pump priming funding back then. And Chris, of course, was one of the founding members, along with Arne and Sagar. And since then, Francis Elmsley is now the lead for running the TS service. But following the 3 major trials, EXIST 1, 2, and 3, and the ready availability of mTOR inhibitors, which were approved by NHS England for use in TSC-associated renal angiomyolypomas, for SAGA in 2016, and then for refractory epilepsy in 2018, we were able to found the TSC Renal Clinic, which I helped to set up in November 2016 with Chris, to accommodate the much inflated need for clinic space in order to see all of our patients on everolimus treatment, who've been treated with mTOR inhibition. And we've continued to work to further develop aspects of the service, both to accommodate an ever-increasing number of patients treated for angiomyolypomas, for refractory epilepsy, and for SAGA. And we were fortunate enough to be assisted with Novartis and St George's Trust in a joint working project which started in December 2019 when we were joined by Lydia Israel, our TSC clinical nurse specialist. And many of you will have been able to talk with Lydia about your relatives or your own care, and hopefully have been able to benefit from her expertise in helping to ensure things happen for you. And so our TSC service is super regional, so it doesn't just have help patients in the southwest of England, but essentially we see patients from nationwide, and we help to oversee the care of patients with TSC and their families from across the spectrum, from local counsellors, from management consultants and artists to patients who are fully dependent for all of their activities of daily living. We've got very close links with our patient association, the TSA, and thus we constantly name drop them, of course. And we recently helped with hosting the very successful TSC International Scientific Conference last June. And we'll, of course, look forward to the next one in due course. Chris and I and our many collaborators across the UK joined to author this set of expert recommendations for the provision of coordinated care, really illustrating a hub and spoke model for coordinated care in tuberous sclerosis complex. And we published this as part of a number of publications alongside the large TSC observational study back in 2019. So this is finally published just 1.5 months before minor issue called COVID-19. I don't know if you've heard of it, but this broached our doors just a couple of months later, and indeed the first cases had already been identified back in November 2019. We will just illustrate with a few more slides in how our clinic has evolved with COVID-19 and has maybe developed, and some have been good developments that have helped people and some have been less good developments that haven't. Anyway, this is our service. We have one TSC genetics clinic each month, and that serves as a diagnostic clinic where we are essentially seeing new patients and seeing and following up our older patients and evaluating how restaging their disease each time and trying to help in creating a bespoke management plan for each patient, really. And it's not possible for us to do absolutely everything for everyone. We are incredibly reliant on the many different people that are involved in any one patient's care. And so I suppose the buzzword for the TS clinic is networking, and using the genetics clinic as a hub and trying to help to ensure that every aspect is tackled as best we can. But of course, there's always something that we can't do, sadly. In the TSC renal clinic, which was founded, as we said, for treatment, we have one clinic per month, and that is bursting at the seams. We started off with one patient back in November 2016, and all of a sudden we now have 92 patients on treatment, and one clinic a month seems awfully little to be able to manage everyone, monitoring them on a 3-monthly basis. We also have a 3-monthly regional multidisciplinary meeting in which we discuss and agree management, whether or not it's contentious, barn door, or just networking to help to all of our colleagues across the country in agreeing management plans for their patients. We have a web page, which is, I mean, if you just Google St George TSC Clinic, I think St George's still comes up as the first hit. So I think that's a product of writing down the words TSC Clinic, tuberous sclerosis complex clinic, and St George's several times in the description, and suddenly Google likes that. So we're a top hit, but that's where we are. We're reliant on an enormous multidisciplinary team. So it isn't just our TSC clinical nurse specialist, Lydia Israel, who acts as the hub of the hub, if you like, and helps to ensure that all of us are on top of our game, or at least trying to catch up with where we're supposed to be. We also have genetics counsellor, Ginny Attard, our geneticist who also leads the service, Francis Elmsley, Chris and I are the nephrologists, the kidney doctors in the room. We also have neuroradiologists, renal and general radiologists, interventional radiologists who help where this is necessary. Of course, it's less necessary these days with the advent of mTOR inhibition, but it's still important to have important consults with those interventional radiologists to see what's possible, what's practical, and work out best interest decisions for patients. We have neurologists who are specialised in epilepsy medicine, neurosurgeons, paediatric neurologists, psychiatrists, respiratory physicians, urologists, paediatric urologists, a learning disability team, a fantastic team of 3 people who help to make reasonable adjustments for all of our patients. And these, they and our anaesthetists and our radiology coordinators work as a fantastic team to make sure that that our patients get the best possible experience in what would otherwise be sometimes a bit of an ugly experience with general anaesthetics and imaging and phlebotomy. So trying our best to make these reasonable adjustments is really central to what we do. Cardiologists, this is one aspect where we haven't managed to finger one individual cardiologist. We have an enormous set of cardiologists who are all equally interested in congenital cardiac disease, and there isn't any one particular lead, but they are very helpful and amenable when it comes to sorting out echocardiograms, sometimes under general anaesthetic as need be, but again, it just requires a lot of coordination. We have an ophthalmologist who has been very helpful. We have dentists, again, a large number of dentists, but no one individual. And of course, a fantastic set of administrative teams in the radiology, genetics and renal teams who just help to smooth things over. But that's just at St George's. What about the spoke? So we talked about the hub. With the spoke model involves that involves all of the different the fans out for every for the local care for all of our other patients. We also ought to mention Brighton, because of course Chris also leads the sub-hub of the TS clinic over at Brighton. I think it's probably an awkward analogy if we're thinking of hubs being wheels, and if you've got a hub and a sub-hub, you'll end up with a wheel that doesn't quite turn around. So there's probably a one weakness to our analogy of hubs and spokes and moving smoothly. But anyway, Brighton is our sub-hub, and we also are reliant on our TSA advisors, as many of you whom you all know. All of our patients, general practitioners, their local learning disability and mental health services, to local specialists at their local district general hospitals and the community. And we are often communicating directly with those local specialists to help for example, in talking about the most appropriate next medication, whether or not that medication is going to interact significantly with everolimus. So newer anti-epileptic medications in particular are an important source of consultation between ourselves and local epileptologists, and of course other nurses and healthcare professionals in helping to get the best care for each of our patients. Just to illustrate what our clinic does and where everyone's coming from and how busy it is. Over 2019 to 2021, things have got more busy. So if you just look at these numbers, total clinic attendances at one of our clinics, the TSC Genetics Clinic, was 186 in 2019, mid-pandemic was 187, and then halfway through 2021, still mid-pandemic, we were up at 97 after 5 months. So the numbers had more than doubled over the course of the numbers had actually doubled by the end of 2021. So our clinic is getting busier and busier and busier, both in the genetics clinic and in the renal clinic. How did things change? Before the pandemic in early 2019, we were seeing patients just face-to-face. And then when the pandemic hit in March 2020, we went almost entirely to virtual clinic appointments with the odd emergent face-to-face appointment. And we've gravitated more towards what is logical, which is patients generally wanting the best of both worlds, both to see us face-to-face on a regular basis, but at the same time, where it's possible and face-to-face appointments are either less convenient or what we need to do can be followed up remotely because we've already seen our patient. We kind of have a clear idea as to what's happened 6 months ago, and we just want a telephone consultation in order to firm things up. So a mixture, and generally speaking, we see people 50-50 face-to-face versus virtual consultations. Virtual consults, they have an important role to play. They also have their limitations, of course. Unplanned contacts. So this is possibly Lydia Israel, our TSC clinical nurse specialist, favorite slide, as it really does illustrate how busy things get. In 2020 to 2021, Lydia has managed to deal with over 1,800 unplanned contacts, either via phone calls or emails. And of course, much of this is illustrating the uncertainties surrounding the COVID-19 pandemic and being on everolimus. And so we can track this as with the number of consultations in each month has gone up and down. And here we've got March 2020 as being a peak, and then a trough, and then another peak around the next wave, and again at the next wave. But generally speaking, unplanned contacts are going up. So the central need to have a TSC clinical nurse specialist to help manage unplanned contacts is very important. Distance traveled to the TSC clinic. So broadly speaking, around about 50% of our patients come from over 100 miles. With the advent of more and more local TS clinics, we would hope that over time there'll be more good, high quality care available to all of our TS patients across the UK, and helping all of our colleagues across the UK to develop exactly very similar services to what we do is really one of our raison d'etres, and increasingly our MDTs involve communicating with and talking with our specialists across the country to agree on management plans. So in summary, since Lydia Israel joined us in December 2019, and despite the COVID-19 pandemic and the lockdowns, we've had an increase in patients seen in both the TSC Genetics and the TSC Renal clinics. We've had a decrease in the number of cancellations and non-attendances at both clinics. We've had a general evolution towards a mix of face-to-face and virtual clinic appointments. We've had an increased number of unplanned contacts, which have mostly been managed by our clinical nurse specialists. We have had very embarrassingly good patient survey results, which is wonderful to see. Of course, we always learn more from the negative survey results. So we always look forward to negative feedback. But yes, it's been all very positive, which is nice. And in our GM UK guidelines for the management and surveillance of TSC, we did an audit against the current UK guidelines, and we've managed to maintain the quality of our service over the last 18 months, which has been a real achievement in the middle of the pandemic. And of course, we did lose our clinical nurse specialist for 2 days a week to dialysis in the intensive care unit. So managing to continue to do what we do despite the pandemic has been a real test of our ability, but we thankfully managed to get where we are today. And we continue to build on our strengths, and of course we're committed to building on what we know to be weaknesses in the service too. In terms of patient and professional engagement activities, well, we're of course delighted to be talking to you, Chris and I, today, but also Lydia, our TSC clinical nurse specialist, has presented to the Early Career Research Network meeting in November 2020 with it, and has participated in TSA organised education sessions and patient education sessions, and presented to the local department in the renal unit back in September of last year. And then, gosh, that's almost a year ago. Time does fly, doesn't it? And then Dr. Elmsley has chaired 2 educational webinars for TS patients supported by the TSA, and Dr. Kingswood has led the scientific committee for the International TSC conference in June last year. Chris, I and Francis also chaired sessions in that conference, and then Chris has just been to what he tells me was the most interesting city in the US, in Texas, for the 2022 TS Alliance World Conference, which if any of you got to join it online or face to face, really was excellent, and some of our wonderfully talented colleagues from the US and around the world were able to join and give all of us some fantastic insights into where things are from around the world too. And it's always gratifying when you listen to world experts and you realize that what you deliver yourself isn't so very different from everywhere else too. So I think that was quite helpful. Networking, this is a really important part of what we try to help do alongside the central role of the TSA. There are 20 clinics at the last count, and we know that there's one more in Norwich coming along, but it's growing, and we're hopeful that people won't have to travel more than 100 miles in order to get to see us and to get the care that they need. But by evolving the virtual clinic, we hope that we're able to continue to deliver a service of good and adequate quality to ensure that patients are treated and managed completely and safely, but helping to develop all of our local specialists' expertise in the condition is really important too. So this is just a list of all of those clinics. It's freely available on the TSA website too. Luke, I think we do need to remember to add Brighton and Norwich onto the list too. So that's one thing to do. Future work. So this is what we've got to do next. So we're still engaged in reporting real world outcomes for patients with TSC on everolimus, because of course there is a slight difference between the environment involved in treating patients in the real world compared with the very controlled environment of clinical trials for EXIST 1, 2, and 3. We're looking to standardize the interpretation of cross-sectional imaging of CT and MRI scans in tuberous sclerosis complex. This is an important research project because looking worldwide, there aren't any international standardized guidelines for how to look at kidney angiomyolipomas, for example. We were awarded a small grant by the Kathleen Vallis Charitable Trust to look at TS responses to COVID-19 vaccination in TS, and many of you have been involved in this project, and thank you very much for doing so. And this will hopefully give us greater insights into how patients following immunization react to the vaccine. And we're also looking at how, particularly for patients who are slightly needle phobic, whether or not we can get similar blood test results using finger prick testing. And this is a very exciting and very important development that we're looking to make, but of course we can't take that step without a degree of research. So that is one of our next projects. And we're also collaborating with our colleagues in Cardiff on the genes in the kidney study, collaborating with our colleagues in Birmingham on the e-snore study, and collaborating with our European colleagues led by Petrus de Vries in the European collaborative study into TAND called Tandem. And you will hear about this and you will see this logo a lot as the Tandem app, which is soon to be released and will allow you to log your patients or your experiences of TS, which may be related to TAN. I think there is one more slide that's somehow missing, and that is the TSC, the European TSC app that we are developing.
No, Nick, we've axed that for the moment because it's
We
not
axed
public
it.
yet.
Oh,
We are
right.
working on that.
We're working on something that is very, very important. There are many, many other things. This is just scratching the tip of the iceberg. So in order to keep us all busy, we've just listed a few of the things that we're doing. Okay, let us just end on flowers. This is back when the St. George's Gardens had lots and lots of water, and hose pipes were still allowed. It doesn't quite look the same at this time of year, unfortunately, but yes, we're open to any questions. Thank you all for your attention.